couple new dad jokes for you. I'm pretty excited about this.
We're gonna intro an episode, my guy.
Oh, okay.
I just said that right out loud. I didn't
I
think that
wasn't. I
part.
wasn't
I said
listening.
it out
I
loud.
wasn't listening.
We haven't perfected
He was so focused on the dad jokes
so excited.
that he couldn't
Trying
even.
to memorize it.
He was just like, head down, blinders on. Got a nail these jokes. What's watching?
These cards now.
Ready.
Did you memorize?
First one. Right.
Okay, well
First.
let Rick introduce the episode.
Danny, how you feeling today, buddy?
Feeling real good.
Because we got to here for another episode of the Rick and Danny show. I see you're chomping at the bit to tell me something. What's going on?
Well, a special employee at the Beaches office gave me a whole stack of dad jokes. I'm pretty excited about it. Pretty excited to share some of these dad jokes with you, Rick. I know it's been a little while since I was able to.
Now, let me ask you a question,
Yeah.
personal question. When they give you these cards of dad jokes, do you take that as a sign of love because they care about you enough to get you these, or is it a sign of sadness because they're like, wow, your jokes have been so bad. Here's some material to
Mm.
supply you with for the next time you have to do the dad jokes. Where do you fall? How does that make you feel?
I never thought of it that latter way, Rick. Made me a little sad to think about that. But
Love you, Danny.
no, I take it
Love you,
the former
Danny.
way
Okay.
as a compliment, and
That's how I would take it too.
you
I
know that
just, you know,
they love us, they love the show, they want to contribute to these wonderful dad jokes that we provide.
I would take it as the nicer way too. I just like to stir the pot.
You've given him a complex now. Thanks for that.
No.
I don't think that was me.
All right, first one. Here we go, Rick.
Okay.
What did the pirate say on his 80th birthday?
I don't know.
Hi, matey.
I enjoyed that one. Not because of the punchline, but because of the delivery. It's a 10 out of 10. That was a 10 out of 10 delivery.
I'm so upset. I've never been so upset that we don't have video on right now. Danny trying to hold in the laugh. The
I'm not good
excitement.
at that, by the way. I'm not good at
Excitement
that.
across the table.
That was a 10 out of 10
That was
delivery.
really
Thank you. Number 2. You ready for it?
Hit me, dog.
I think you'll appreciate this one.
Okay.
This one. Did you know that dogs can't dogs?
Go dogs.
All right, I gotta start this over.
Okay, I got a quick tangent.
Yeah, please.
So I need you to ask about this, if this is true or not. So I saw something on X now about this Georgia message board. This guy was basically like, they need to not allow kids and women into Georgia games anymore because they're ruining the atmosphere and not like aggressive enough for what they want. And so get Thomas's opinion on how he feels about that.
I definitely will.
And then the other thing I saw or heard about on Georgia message boards is that if you on Georgia football Saturdays, if you walk into a church on Saturday in Georgia and you're not met with a resounding and it's not the right church for you. Is that just find out if these are factual
I'll
statements?
look into it. I
Okay.
think the bigger question though was, why do you have so much stuff about Georgia message boards?
That's
Oh,
interesting.
because I follow some of the greatest troll Twitter accounts of all time. There's one I highly recommend. His name is 3 Year Letterman.
Yep, you
Oh,
have recommended him.
oh, he's the best because he's a Georgia fan and he just trolls everybody and it brings so much joy to this person's heart.
And that's this person.
With me.
That's cool.
It's hard.
That's cool.
It's a hard one. Okay.
All right, I'm ready.
You good, Danny?
I'm
You
ready.
refreshed?
Ready.
Okay, sorry. Oh, dogs.
Did you know, Rick, that dogs can't operate MRI machines?
I did not know that.
CAT scan.
I get it, but also like not.
What do you think? I mean, not 10 out of 10, but not bad.
I like the pirate one
The
better.
pirate run, yeah.
I like that one.
Thank
They
you.
were both really good.
Thank you.
And you bring a lot to this group.
Thank you. Thank you.
So was it worth it to
appreciate
wait
it.
around for that, Lauren?
I think it was the CAT scan. I mean, it's fitting in with the medical theme, but
Yeah.
Mm.
Not as good.
the
Okay.
one was really
I
good.
liked it.
9 out of 10.
Thank you.
I liked it.
If you want to contribute to future dad jokes, you can always email me.
Okay.
CSNF account. Open to all kinds of recommendations.
Sweet.
Yeah.
Sounds great. I'll definitely,
Or
keep
don't
in
or
mind.
don't.
Please do.
Or email. Ideas. I don't know that we can do a whole episode. We'll do a
Just
quickie.
yeah.
All episodes.
All right, we got a couple of. Now, I haven't read these articles, Rick.
Okay.
Surprising, right?
So you're
Um,
saying you came prepared,
yeah, but
as prepared as I am.
as prepared as we
That
were
is-
for this recording here, you know. So, anyways,
that I scheduled 3 days ago.
3 days ago.
Thank you guys.
But I'm pulling some New England Journal Watch
Mhm.
articles. All right. So these are coming from all over the place, coming from Lancet, New England Journal. We'll get into the details. The first one I thought we'd go over was one that incorporated stereotactic ablative radiotherapy, and it was looking at adding immunotherapy to stereotactic ablative radiation treatment for early stage non-small cell lung cancer. Have you come across this, Rick?
Mhm. Yeah, we had a trial open here called Pacific 4.
Still enrolling?
I think it's filled its enrollment criteria.
Enrollment, yeah. So this one got reported in Lancet, phase 2 study, and they were investigating patients who had inoperable stage 1 or stage 2 node negative non-small cell lung cancer. Um, and what they were investigating, this was an open label study, 156 patients. Patients needed to have non-small cell lung cancer, tumor size less than 7 centimeters, node negative, and they were randomized to either SABR, stereotactic ablative radiotherapy, or SABR plus nivolumab, which is immunotherapy. The stereotactic radiation was given at 50 gray in four once daily fractions, or they could give it in 70 gray in 10 fractions. And is that standard, Rick?
It's yeah, part of within the general standard of care. There's a wide variety of ablative fractionations that would be part of it.
Nivolumab was given intravenously every 4 weeks, which is a standard way you could dose it. You can also dose it every 2 weeks. And it was given on the same day as the first radiotherapy or first radiation treatment, or within 36 hours after the first treatment, and done for 4 cycles, so four treatments, so over about 3 to 4 months. Median follow-up was 33 months, and they had event-free survival as their primary endpoint. And in the immunotherapy plus stereotactic radiation arm, 77% of patients were event-free, compared to 53%.
It's okay. Now I just have a bunch of cuts of you saying
No,
No.
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 All right, let's wrap up this
Let's
Yes.
do it.
little convo here. So we were going over results of the study. So median follow-up of 33 months, 4-year event-free survival uh, was 77% in the arm that received immunotherapy plus stereotactic ablative radiotherapy, and 53% in those who just received stereotactic ablative radiotherapy without immunotherapy. There were no grade 4 or 5 adverse events, thankfully. I wouldn't expect there to be, but thankfully. There was no grade 3 pneumonitis, which is good. I'm actually a little surprised about that, given they included tumors up to about 6.9 centimeters, Um, and only 8 people discontinued nivolumab over the 4 cycles. So my thoughts on this, interesting. I think that in medically inoperable stage 1 and 2 non-small cell lung cancer, especially, the way I think about this for stage 2 patients, like if I have a stage 2B, I'm considering giving chemoradiation treatment. You have a Hyler node that's positive.
They excluded nodes, right? On
Oh
these
yeah,
guys?
yeah, yeah. So they excluded nodes in this, but a larger tumor, I don't know. I haven't really had many of those in my practice yet to have like a 5, 6 centimeter tumor,
Hmm.
node negative.
Yeah, I mean it's pretty
Yeah,
uncommon
not all the
scenario.
time that you see that. So I guess this shows that you could give stereotactic ablative radiotherapy to the lung plus immunotherapy and have a pretty good 4-year event-free survival without recurrence, about 20, 25% recurrence, roughly. Um, but can you get that authorized by an insurance company to say, I'm going to give 4 cycles of Opdivo with stereotactic radiotherapy? I'm not sure that that would get approved just based on a phase 2 study. But it shows, I mean, it actually shows, the kind of high rate of
Yeah,
events
what was it? What
in
were the numbers again? Can you remember?
53%
Yeah, it doesn't make sense.
stage 1, 2 node negative,
With the ones that did not get
event-free, 4-year event-free survival, 53% in the ones that didn't get immunotherapy,
versus 30s.
77.
Yeah, I mean, those numbers don't jive with the phase 3 data.
So you're talking about like a 25% difference
Yeah, I
event-free
mean,
survival.
if you look at the best SBRT data we have with
Right.
long-term follow-up, going out 3, 5, even some
Hmm.
7 years, eight
Yeah.
years, you're talking usually, roughly speaking, local recurrence risk is alone is pretty rare.
Right.
That's like, less than 5%. Nodal recurrence, usually on the order of somewhere between like 20, 25%. And
Hmm.
then nodal plus distant recurrence, meaning they fail anywhere. Those roughly speaking at about 5 years is 1 in 3. 33% based on um, more
So yeah, this
mature
is
long-term data. So
definitely
those
higher than
those
that.
failure
Yeah.
rates are higher. Now that may be due to the fact that they included
Large.
some larger tumors.
Yeah.
I don't know specifically,
Right.
obviously, but
Right.
so that's the only thing I would say is, like, other than it, of course, not being a phase 3, but the main thing being, I don't know if those historically the numbers
Hmm.
on the nivolumab arm are kind of more what I would expect with just radiation alone. But I think it's definitely worth pursuing in a bigger trial. I mean, I think there's enough preclinical data, relatively clinical data, that you would
Yeah.
consider it. Thinking of especially extrapolating from, we give chemo and larger tumors after surgery, things like that. We know there's
Mhm.
data for. So,
Yeah.
you could make some
Yeah.
similar arguments, but I think Pacific 4 should be the best test because I believe that's going to be a phase 3.
Hmm.
Lots of patients, and they're stratifying by tumor sizes too. So we'll
Hmm.
get a breakdown of maybe it only benefits the really big tumors and doesn't benefit the smaller tumors.
Is that squamous cell and adenos?
Hmm. Yep.
Both. Yeah.
And then I
Yeah.
think the other thing too is, did they look at driver mutations in these?
Right.
Did they do any of that? Then, to your point, for larger tumors, especially node positive tumors, we would, if the patient can handle it, chemo RT, I think would maybe be a preferred modality
Hmm.
versus SBRT. Um, so I think those are kind of my initial thoughts about
Right.
it. The other thing though with the chemo is a lot of times some of these patients we're getting to do radiation,
Hmm.
some of them aren't even chemo candidates, and not obviously
Right.
surgical candidates. So sometimes you're
Right.
just kind of stuck between a rock and a hard place. But they may be immunotherapy candidates, but not
Right.
traditional chemo candidates.
And the ADORA trial for adjuvant, after, well, so we have adjuvant data postoperatively. We don't have post chemo RT or post radiation data on giving targeted therapy
X.
like EGFR inhibition, but that is coming out. At least for chemo RT, it's going to come out, I think, for the stage 3
Yeah.
patients.
I mean, I would
Um,
imagine it would be similar to the results in
right,
Adora.
right. Or ADORA's postoperative. But not everyone in ADORA received chemo.
Right.
But
And that was a little confounded because that was the one that they didn't MRI everybody
mhm,
beforehand, and
yeah,
um,
yeah,
so there were
right.
some thoughts on that too.
So that's interesting.
But yeah, no, it's a good. I mean,
Yeah,
I think this route of treatment is certainly worth testing more. But I agree with you in that I would not routinely recommend it in practice at the moment.
yeah. Yeah, I wonder what the breakdown in, the grading of the tumors, how many were squamous versus adenos, et cetera, and how big were the tumors and the breakdown of the sizes. So, if I had the full article, I could tell you that, but I don't. So we'll move on. Let's see what else we can find real quick here. I actually talked to Dr. Sugarman about this. This was kind of interesting. Get your thoughts on it. All right. All right. So this was another article Rick reported in Journal of Clinical Oncology in August. And I don't have the full article in front of me. I've just kind of some salient points here that we can review. Um, this was a Canadian study, it looks like, randomized trial comparing FDG PET CT scans to conventional staging scans, which would be CT and bone scan, in 369 patients with clinical stage 3 or stage 2B breast cancer, who were being considered for curative intent therapy, including surgery, radiation, and systemic
And
therapy.
what was the conventional imaging again?
Bone scan and CT chest, abdomen, and
Got it.
pelvis. So, due to concerns regarding PET's avidity for lobular cancers, only ductal carcinomas were included.
That makes sense.
So, overall, 23% of patients in the PET CT arm were upstaged to stage 4 disease, compared to 11% in the conventional arm. Absolute difference of 12.3%, which was statistically significant. As a result, treatment was changed in 81.3% of upstaged patients in the PET CT arm and 95.2% of patients in the conventional arm. That was kind of interesting. I don't know the total rationale for that, because I would imagine you upstage to stage 4. Why wouldn't you have I mean, other than people refusing therapies potentially, or
Maybe it was like
your
low
discussion.
volume oligometastatic,
Right,
and they said, well, we still want to proceed with definitive treatment to the
right,
breast. And
exactly.
yeah,
Which we know the data is a little murky on that.
correct.
So, PET CT detected more distant metastases than conventional staging. Again, conventional was CT, chest, abdomen, and pelvis, and bone scan imaging. And fewer patients in the PET CT arm received combined modality therapy. All right. So, the summary here is results indicate that PET CT is more likely to identify sites of distant disease than conventional imaging, leading to radical change in the therapeutic approach and goals of care in a significant fraction of patients. Remember, absolute difference in detecting metastatic disease was 12.3% of people. A key question left unanswered is whether preferentially employing PET CT adds clinical utility. Do patients who have indolent distant disease identified have equal or better outcomes than those who have indolent disease not identified? So, um, and I mean, that's a whole question too of imaging people and when do you find recurrence and metastases? Does it matter? Does it actually impact survival? There are some studies that show that doing more surveillance imaging and detecting metastases early don't necessarily lead to improved survival. So, versus waiting till they're symptomatic.
Yeah, I mean, I think you have the classic Will Rogers phenomenon where you have a better screening test,
Mhm.
so there's going to be stage migration.
Right.
So everyone's outcomes are improved, right? Because the stage three outcomes are improved because you're
Mhm.
better selecting people who are really stage three if their pet's negative
Right. Right.
versus maybe in the past having people who had microscopic or macroscopic metastatic disease.
Yeah.
Conversely, stage four outcomes will be better because people who formerly were stage three are now moving into stage four with better. So it's
Hmm.
some part of the reason the outcomes get better with better detection imaging is
Right.
you have that stage migration there. Um, so I think from that standpoint, it's interesting. But the more salient point, if you're the patient, is if the pet's positive, should it change what you would do?
Hmm.
I think, you know, this it comes down to the individual patient versus what's best for the on a population level. And
Hmm.
sometimes those two things aren't, you know, because of cost and things of PET scans, it
Right.
may not make economical sense to get every breast cancer patient a PET, but on the individual patient level, I think it's nice to have that data and you can make
Yeah.
more informed decisions. But no, I agree. There's still teasing out who it matters in and who it doesn't is going to be a challenge.
Yeah. I don't think this can be, and I doubt the NCCN guidelines will change, but I think in our practice, we tend to order PET CT scans in stage 3 breast cancer
Hmm.
patients. Um, Maybe those with less resources would not choose PET CT, especially if a patient has to travel a long distance to do a PET CT scan. And if you have CT scans available, bone scans available at your institution. But nowadays, if you have a bone scan
I feel like
capability, like
pet's
you're
pretty
gonna have a pet,
ubiquitous these
right?
days. Yeah.
So it's yeah. I mean, I think we're doing that in practice, stage 2B patients. I think you know, I think most of our patients are getting PET CTs in this setting already. So I don't think it's changing what we do in this practice, but
Do you run into insurance pushback often on those patients?
I have not. Dr. Sugarman has a bigger group of patients, who she treats for breast cancer, but I have not run into issues. So
Curious.
I do find it interesting, though, breast being one of the cancers, and again, it's a heterogeneous disease, but whereas lung cancer and other types of solid malignancies, we sometimes try to treat to cure, even if that chance is low with oligometastatic disease, but doing that in breast hasn't really proven to be a curable
Yeah,
strategy.
it's interesting because the biology of some of the breast cancers that are on these studies are actually the more indolent biologies,
Hmm.
right? So the
Right,
patients do really well,
right.
but being aggressive with local therapies doesn't seem to impact the ultimate disease course. It makes you wonder, is
Hmm.
it is that because the lesions that are always treated do well? So
Right.
the question is it because it's such an indolent biology? Is it
Hmm.
just that these women have they're sort of circulating tumor cells either in their marrow or in their blood, like at all times? And
Yeah,
it's just so indolent that it's not exploding,
right.
but they're kind of already have seeded all these other areas, and we're just not catching it at the point they're
Hmm.
oligometastatic, versus lung cancer, which obviously there's different biologies, but tends to be a little more you
Right,
kind of blossom or you don't.
right.
It's, you know, completely just
Yeah,
hypothetical. I have no idea if that's the reason why, but it makes you
right,
wonder because the outcomes for these patients are, usually really good. They
right.
live a long time.
Hmm.
Some can be controlled for years and years and years, you know. But you would think
And that,
you would think that would mean the local therapy would help, but in
right.
but in breast cancer, the data's not panned out.
That kind of it goes to the point where I forgot if it was called the Sonia study. Remember, I think it just got reported in ASCO, randomized people to starting with AI, their metastatic hormone receptor positive breast cancer, AI versus starting the CD4K
Hmm.
upfront with AI, um, and then second line being fulvestrant in the if you failed CD4K, and if you failed AI, you go to the CD4K. So using
Right.
CD4K or
First or second.
CDK4/6
Yeah.
in the first line versus second line, progression-free survival was the same,
Right.
and overall survival seemed to be the same.
Right.
So you kind of, to your point, in breast cancer, going aggressive up front with a higher toxicity treatment isn't improving long-term outcomes. Initial outcomes, I mean, tumor reduction is more with those therapies, but you're not getting a longer life because of that.
Right.
You're not seeing improved outcomes. So that's interesting. And I don't actually know. I haven't heard from enough people whether that's actually changing people's practice or not. You get diagnosed with metastatic ER positive breast cancer, start with an AI. I mean, the data seems to show that you're not at any disadvantage to
Right.
getting it in the second line.
And your quality of life will be better for longer.
Yeah. Especially if and the point would be if you're asymptomatic from your metastases.
Right.
If you have debilitating bone pain, you're not going to just start an AI. In my opinion, you'll start more aggressive treatment. But
Don't forget your friendly palliative radiation folks in
yes,
that situation.
yes. And the other thing that's you know doesn't make a whole lot of sense, although I've looked into it a little bit, is all these CDK4/6 inhibitors. There's three of them, and some seem to be more beneficial than others. And then the initial data didn't suggest that, but now that overall survival data is coming out and adjuvant data is coming out,
And the way it works is it just kind of arrests the cell cycle
correct?
in
Yeah.
allegedly a more sensitive phase.
So apparently there's CDK4 and CDK6 that kind of regulate the cell cycle through cyclin cyclin D1. And by inhibiting that, you're inhibiting the cell cycle. And if you have more of CDK4 inhibition, it's actually better At least that's what they think. So that's why they think some of the oral agents have more for
But
inhibition.
is the mechanism of action of the way it's actually killing the cancer cells is just preventing mitosis,
Right.
or does it work because it puts the cancer cells in a state that's more sensitive to another therapy, or is it the actual stopping of the cell
I
cycle?
think it's the stopping of the cell cycle.
That's interesting, right? Because it would arrest it in S1,
Hmm.
presumably,
Hmm.
but that's also the phase of the cell cycle that's least sensitive to, most resistant to things like radiation or
Yeah.
other chemos.
Right.
So it's
Right.
very,
Yeah.
you can play this game of like mechanistically, what works, what doesn't.
Right.
Because
Yeah.
obviously, like alkylating agents and stuff work in the more in the S phase, my actual mitotic phase,
Hmm.
versus if you arrest the cell in S1, are you creating clones that are,
Yeah.
I don't know. It's,
Yeah. It's
theoretic.
just, yeah, that's interesting.
Well, people
Definitely.
smarter than me will hopefully figure that out.
And
And
more time to learn about it.
Brenna's asleep.
I woke up just into
So I think that means we've nailed this episode if
Yes.
we've
pretty
put
good.
Brenna to sleep.
Yep.
But thank you for bringing those articles in, Danny. I think it's very interesting.
Always a pleasure, Rick. Until next time.